pointing to the discussion I think we're going to have here today. One of the things, real quick, one more advertisement. You heard me mention earlier today about our new Policy Perspective series. We're going to be conducting more events like these around the state and via webcast in the next year, part of a new series that we're launching. You will see, for instance, the next one of those will likely be a webcast about the governor's proposed budget in that first few days after the budget's been released. We'll then be doing a series of events around the state in Southern California, Northern California. We're looking for partners to do those in some other regions, so if your organizations would like to do that, we'd welcome those invitations. And we'll be doing some webcasts throughout the spring on budget issues. So this will not be the last chance you have to learn more about what's happening as things go forward. So it's my great pleasure to introduce our panel of experts here. First, far to the left here is Edwin Park, Vice President for Health Policy at the Center on Budget and Policy Priorities. Those of you who have attended our conference before know Edwin well. We have him regularly to talk about the interaction of federal and state health policy issues. Internally as staff, we talk about Edwin's groupies, who are always really excited to have him on the program. So we're really glad to have him back. I think most of you know that we have a long-standing partnership with the Center on Budget and Policy Priorities. I think the work we all do together is going to be more important than ever. So Edwin, thanks for being here with us today. And then here, just to my left, is Frank Mecca, the Executive Director of the California Welfare Directors Association. Frank's also a longtime friend. He's a member of the Board of Directors. Our two organizations share information back and forth a lot about what's happening in the state budget and around state policy issues. And so Frank, thanks for being here with us as well. So if you've been to this event before, you know that we typically structure this event to be almost entirely focused on what the issues are going to be in the coming budget deliberations, and to provide a little bit of a snapshot of that. And as the questions that came up in the earlier session indicated, that is, the answers to those questions right now are so determined by the 2016 election and what we think is coming, or the uncertainty about what is coming in a number of key areas, and the interaction of what might happen with the federal budget and what that means for the state budget. So we've structured this session with these two experts to talk about what's coming, in particular what's coming with the Affordable Care Act, what's coming with some of the other potential changes in the safety net arena, and what federal actions and changes might mean for the California state budget. So I'm going to start with Edwin, because I think the question that's been first and foremost in everybody's mind, certainly most covered in the media, is about the debate that's coming about the Affordable Care Act, so-called repeal and replace. And then I would like both of you to talk a little bit, and I'll follow up with you about some of the specifics about what that might look like going forward.
Sure, thanks, Chris. So when we look at the historical progress we made in reducing the ranks of uninsured over the last several years, I think it's important to look ahead in 2017 as not only losing all those coverage gains, but taking huge steps backwards even before where we were in terms of coverage pre-Affordable Care Act. So the current plan is that in the end of January, congressional Republicans will pursue what's called budget reconciliation, which is an expedited process to repeal the guts of the Affordable Care Act. The major coverage expansions would be eliminated after 2 or 3 years. Some provisions like the individual mandate, the requirement to have health coverage or pay a penalty, would be eliminated immediately. Based on the Urban Institute estimates of that repeal approach, it would add 30 million people to the ranks of the uninsured by 2019 and cause immediate chaos in the individual health insurance market across the country, driving up uninsured by about 4 million, driving insurers out of the market or requiring them to charge much higher premiums. So this will likely happen at the end of January. There's a campaign to oppose that called Protect Our Care that a bunch of national organizations have put together. But I think we'll get into the details of the Affordable Care Act repeal, but it's important that this is just the first step. The Affordable Care Act repeal does not include a replacement plan, despite what congressional Republican leaders have promised. So it's effectively repeal. There's no indication that there is a replacement plan. Congressional Republican leaders have had 6 years to put together such a plan, but there is no consensus plan, particularly among Senate Republicans. So if there is a replacement plan, it will come up later in the year, and that may be part of a second reconciliation bill to pursue both big tax cuts, billions of dollars, trillions of dollars in tax cuts, primarily focused on the high income, as well as other changes to the healthcare and social safety net. Because one of the key proposals is to cap federal funding for the Medicaid program, which funds the Medi-Cal program here in California, on top of the repeal of the Affordable Care Act, that's why we would take huge steps backwards even before 2009. The House budget plan from Republicans this year talked about cutting federal Medicaid funding by another $1 trillion over 10 years on top of repeal of the Medicaid expansion as part of an ACA repeal proposal. So these are huge cuts, much greater flexibility given to states as part of that, but the cuts are so large that states have no choice but to dramatically scale back their programs, again, going well beyond losing the expansion, but cutting the program that was in place prior to the Medicaid expansion taking effect in 2014. So these are huge threats to both health care, but also, and we'll get to later, the rest of the safety net, including the SNAP program.
So I have a quick follow-up question, but first I thought it'd be useful to just put out some numbers. I'm sure a lot of you have seen them, but through the Affordable Care Act, we have 5 million people who are insured now who weren't insured before. More than 4 million of those are through Medi-Cal, our Medicaid program. Nationally, 11 million more people in the country are covered now by Medicaid than prior. So more than 4 million of those are in California. So California, more than any place else, has a grand stake in what happens with this. And so you presented it as sort of a relative assurance that there's going to be this is going to happen through reconciliation and some sort of repeal process or effort will be made fairly early in the year through reconciliation. I thought there was still some debate about the timing of that or the process for that. Can you say a bit more?
Yes. So there's been a dry run on repeal of the Affordable Care Act. So people may remember there was a reconciliation bill passed by both the House and Senate in January of this year, vetoed by President Obama. So it's likely that that bill will prove to be the model for a reconciliation bill in early 2017. Both Senate and House Republican leaders have reiterated that their hope is to get that reconciliation bill through, repealing much of the Affordable Care Act by the end of January, so on or soon after Inauguration Day. The hope, of course, is that there'll be some second thoughts about this plan because without any replacement being part of this repeal proposal, this is effectively repeal. This is driving tens of millions of people off coverage into the ranks of the uninsured, losing access to needed care. And congressional Republicans who are generally unified in opposing the Affordable Care Act and supporting repeal, several of them have voiced concerns about not having a replacement plan in place. And as one congressperson from Pennsylvania said, when you have a cliff set up, which is what repeal would do, you can actually go over that cliff. And I think that's, our hope is that there'll be some second thoughts and that plan won't go ahead, but that's the current intent, is to move ahead with repeal by the end of January.
Great, thanks, Edwin. So Frank, your members around the state who administer human service programs with the state and on behalf of the counties are obviously probably pretty concerned and wondering what's happened. What are you hearing from your members?
I think first and foremost is just the same fear everybody in the room has, that 5 million people could lose their health insurance. To give you a sense, for those of you who haven't seen the Budget and Policy Center's recent report, about a third of the people in the state of California are on Medi-Cal. It's amazing, and in some counties, typically counties represented by Republicans, the number is close to 50% or even over. So the the human sort of toll of that is the first concern, and almost so large it's sort of hard to get your brain around. In California, those people who were enfranchised with health insurance were largely, at least with the Medicaid expansion, childless adults. And in California, counties are responsible to be the safety net provider of last resort. So some of these people who could lose coverage would sort of re-qualify for what is a pretty limited indigent health program. Many would not, because the eligibility criteria were much more restrictive in the indigent care program. But there's a pretty complex fiscal relationship between the state and the counties that would have to be unwound. Because when the Medicaid expansion occurred, the state assumed a large amount of what was county revenue under the argument, the true argument, that since you counties are no longer responsible for them, but we will be paying for them under the Medicaid expansion, we need some of those funds. So the mechanics of the unwinding are not insignificant. Sort of from my standpoint, I don't know that it's at all clear what the replacement might look like, what the repeal might look like. I'm choosing not to be so sure that it's going to be as dire as we might imagine, but I don't see any scenario where it's not going to be bad. And so the impact, I think, of just the actions on the Affordable Care Act, notwithstanding the other programs we're going to talk about later, I think are going to cause a real retrenchment and a reticence to make any strategic investments for progressive priorities in California, whether it's health care or beyond health care, whether it's foster care or SNAP or in-home supportive services. Whether the threat is clear and obvious in January or whether it's still up in the air but pending, in either scenario, I think the administration in particular is going to be quite loath to make strategic investments that low-income people and working people need. In fact, I would not be at all surprised if we don't see in the governor's January budget some preemptive restrictions in current safety net spending and programs in anticipation of what could be a huge bill for the state, and a lot of pressure, I think, that the legislature is going to put on the administration to backfill at least for some part of the folks who lose coverage. So I just think it's important to understand. I think the ripples go way beyond healthcare, and I think they go to sort of the progressive safety net and programs for working poor generally.
And just to put some scale to that, I think Scott said a little bit about this earlier, but right now the costs of covering those folks who are on Medi-Cal in California because of the Affordable Care Act is a little over $16 billion. So for California to backfill that at 100%, if it were to completely go away, is in the sort of sense of the state's general fund budget, really daunting and fairly unlikely. And now there's a lot of space between there about where we might end up in terms of what repeal, replacement, other sorts of things might mean. And so I want to go to that question, which is there are a lot of different specific changes that could be made short of sort of outright 100% repeal. So give me a sort of sense of the type of things you might be seeing there. I'm assuming block grants, other sorts of specific ways that might still be bad for California or have significant implications for those who've been covered.
Yeah, I mean, I think that, setting aside repeal, because we're not sure, if there is going to be a replacement plan and what that replacement plan would look like. But there's been a longstanding priority on the part of congressional Republicans to pursue a block grant or a per capita cap. So that's a change to the Medicaid program. So in California in general, federal government picks up half the costs of Medi-Cal. It's obviously higher for the Medicaid expansion. But under a block grant or per capita cap, the federal government will give a fixed pot of money to states like California. If state demand for Medicaid increases, the federal government doesn't provide any more money. So on a block grant, it's a fixed pot of money for the entire program. So if there's a recession, there is unanticipated higher medical costs through a new disease or condition or a new treatment, state's responsible for 100% of those costs. And that's on top of the explicit cut that's built into how the block grant amount is calculated. As I mentioned, the House budget from Republicans this year proposed a $1 trillion cut over 10 years on top of repeal of the Medicaid expansion. By the 10th year, states would be facing a cut of federal funding by about 1/3, about $160 billion. So it's a fixed pot of money that's set well below what's going to be provided under current law. States have to compensate for that. Per capita cap is very similar. It's a cousin to a block grant. Instead of a cap on the entire program, it's a cap on a per beneficiary basis. But again, the amount provided per beneficiary is set at a level well below what's going to be provided under the current financing system. So states have to absorb a cut of, a third or more to their federal spending for each beneficiary, which of course the state has to come up with either more revenues or, far more likely, scaling back the program significantly.
So that raises a good issue here, which is, short of repeal, as you were saying, there are a lot of things that could happen that would essentially leave the ball in the court of the states, but with the states' hands being tied because of the finances and not being able to completely backfill. Frank, you were talking about this earlier with me. Sort of, what do you think some of the other ways that might happen that we should be watching for?
Yeah, so let's say the politics are such that 30 GOP senators that represent states that opted into the Medicaid expansion, or the hospital industry, the health insurance industry, cause enough political pressure that there's some thought in Washington that, well, we can't just sort of bomb the whole thing. We can't just leave 20 million people uninsured. I think there are things that they can do that really shift the onus to states where they don't have to take the political responsibility for disenfranchising people from health care. And I think Edwin discussed two of them, the block grant and a per capita cap. A per capita cap would allow states to get funding as caseload grows, although the rate that the states would get would be capped. I think it's important to point out that that approach really hurts states like California, which have extremely low per capita spending in the Medi-Cal program, largely because our rates are so low. And so if you think that there's a punitive aspect to the way Washington or the Trump administration might look at replacement, there are ways, I think, that they could look that are particularly onerous for states like California, who sort of didn't go for him and whose leaders have largely said we repudiate much of what you stand for and what you campaigned on. There are hundreds of millions of dollars that the state gets in waivers that are optional. They're at the federal government's discretion. Those could be more easily scaled back, and I think politically more easily. So there's a block grant, there's capitation, there's less flexibility in waivers. Washington could say, well, it's up to you states. This is the flexibility that you've all asked for. I think it would be very interesting to look at the new CMS director, the Centers for Medicare and Medicaid Services, was the Medicaid director. She worked in several states, and while in Indiana, had a successful waiver program. And if you look at some of the elements of that waiver, I think they're illustrative. She also worked on behalf of a reform paper, a concept paper for the National Governors Association. And you see things like capitation. You see things like work requirements, what some people have articulated as sort of the TANF of Medicaid, significant increases in cost sharing for beneficiaries, both in terms of premium contributions and copays, tiering of benefits for people depending on their employment status, the undoing of the MAGI eligibility standard, the modified adjusted gross income standard, which is a simplified way people can get on Medicaid in ways that don't count their limited assets against them. So there's a whole host of ways, I think. If the politics in Washington don't line up in favor of a big bang sort of annihilation of the ACA and the Medicaid expansion, there are plenty of options on the table that could really hurt the state of California.
So one of the things I want to encourage everybody to be thinking about is we will be going to questions, and for those of you online, you can submit those to our Facebook page as we've been doing earlier. We'll read them out as they come through. But I wanted to make a little bit of a transition. I'm sure we'll come back to issues around the ACA, but I want to make a little bit of a transition to something that both Frank and Edwin have alluded to here. Edwin mentioned a second sort of reconciliation bill probably coming later in the year. That bill, as he said, could both have ACA replacement or reform elements in it. It will likely have the Trump administration's tax cuts, tax reform proposals, and it's also where we are expecting whatever else might be coming in terms of attempts to cut or reform in some fashion other safety net programs like SNAP or CalFresh here in California. So, Edwin, could you say a little bit more about what those types of reforms and proposed changes might look like?
Sure. The House Republicans, particularly Speaker Ryan, have generally supported the following sort of conceptual framework for tax cuts. So big tax cuts, trillions of dollars targeted to high income, tied together with very deep cuts in spending, of which about 2/3 come from low-income programs to help offset some, but certainly not all of the cost of these tax cuts, which otherwise add trillions to the federal deficit. One of those cuts that has been proposed in previous House Republican budget plans is to convert the SNAP program, which funds CalFresh, into a block grant. So not only would federal funding be capped, we know that CalFresh SNAP enrollment overall rose significantly after the most recent recession. It's a countercyclical program. Under a block grant, again, like with Medicaid, it's a fixed pot of money. States wouldn't get any more for SNAP, even if the demand for nutrition assistance is rising, for example, because of a faltering economy. The House Republican budget this year envisioned a SNAP block grant that would cut federal SNAP funding by about $125 to $150 billion over 10 years, which is on average a 20% cut in federal funding over that time period. So again, big cuts in assistance. Usually they're tied to greater flexibility, like in prior block grants. And so there's certainly a question whether even the reduced amount of funding that's available to states will continue to go to provide direct assistance to families. We've seen other block grants where that hasn't been the case. Nationwide, with the TANF program, only about 50% of TANF funding now goes to core assistance, cash assistance, child care, supportive work.
Frank, you want to talk a little bit about what some of those cuts might mean for the programs your folks administer?
So with respect to a SNAP block grant, I guess a couple of questions. The first is sort of what might be the timing of a SNAP block grant. And I think it's possible that Congress and the president-elect will have their hands full with the Affordable Care Act in 2017, and that SNAP issues are put off for the following year. SNAP is to be reauthorized in 2018, and so it's possible that whatever changes occur in the SNAP program wait until reauthorization, but again, it's really hard to say. The interesting thing about the SNAP conversation is that we've heard some folks in states say, well, depending on the base year, maybe a block grant isn't so bad because our caseloads have gone up so much during the recession that they're likely to come down and this staves off increases, I think, or decreases. I think it's short-sighted for states to think that way. But again, in the SNAP program, there are a variety of waiver programs that could be vulnerable. California, we're an expensive state to do business in, and we've been criticized for having high administrative costs. I could see targets on our administrative costs, which would be unfortunate because it's funding we need to get people enrolled, since we also have lower than average enrollment. There's one other thing that issue that we haven't mentioned, and there's a regulation that clarified that home care workers are entitled to overtime, and California implemented that in our extremely large home care entitlement program, IHSS. If that regulation is repealed by the president-elect, then California legislators face another fiscal dilemma, because the cost of paying overtime, which was assumed to be shared with the federal government, would now have to be borne exclusively by the state. And, you know, the County Welfare Directors Association, we spend a lot of time lobbying the state budget, and so we spend a lot of time trying to put ourselves in the seat or in the head of the Department of Finance, or even the governor's office. And when they line up all the potential threats, what they see is pressure from people like us, which is our job, to maximize the extent to which the state backfills for lost federal dollars so that people don't get hurt. And I think it's important to remember that the governor was reticent on the Medicaid expansion, reportedly. I didn't talk to him about it. But we know the Department of Finance worried that the promise, the siren song of that super enhanced federal match would at some point in the future get chipped away. This is the worst nightmare from the standpoint of their fears when we opted into the Medicaid expansion. So between pressure in the IHSS program, pressure from backfilling on Medicaid, risks to SNAP, and then the spending that the pro tem and the speaker have promised for defense of people against deportation, legal defense for due process for deportation issues, training for public defenders. There was a package of proposals and bills are being introduced. So there's going to be, I think, new spending, appropriately so, to protect vulnerable people from the immigration communities from risks of deportation and harassment. All of those things line up for, I think, what could be a very difficult year in the budget, though that shouldn't dissuade us all from continuing to do what we're supposed to do, and that's argue for the vulnerable people who rely on us.
Well, that reminds me of Scott Graves' introduction at the beginning about remembering budgets are about values and priorities and not just about the dollar and cent side. We have to be realistic about the dollar and cent size and what this means, but we also have programs here that are designed to help those who are the most vulnerable in our state. And so as Frank said, we have an obligation to at least address what backfilling some of the coming changes might mean. Now, one of the comments I did want to make is just how much the issue of uncertainty plays into what happens next. There's some collective wisdom about what the process is going to look like at the federal level, but as we've seen with any administration, things can slow down once they start to govern. And that uncertainty is going to greatly affect what happens here in California. So it's really hard to put out a budget proposal in January that doesn't know what's going to happen with ACA changes. It's really hard to put out a budget in January that doesn't know what's going to happen with CalFresh. And we've been getting a lot of questions at the Budget Center about what that might mean for the state budget this next year. And one of the comments I've been making is about this uncertainty is, look, we're just going to have to watch really, really closely, because if the Trump administration and Congress are able to move aggressively, as they say they would like to do, by the May revision, we could have a lot to respond to in the state budget. If they're slowed down or it takes them longer and the collective wisdom about this second reconciliation bill is later in the summer, we may have not very much information to go on. And so that may foster even more of a sort of sense of let's wait and see, be very careful. And one of the things we haven't talked about here is that I think is pretty easy money as a bet goes, is that we're going to see the governor's office in their proposal in January double down on the rainy day fund. deposits. So just like this last year, before this election even happened, the governor put more dollars into the rainy day fund than were required by Proposition 2 in the Constitution, and he was successful in getting that through in the final budget bill. I suspect we'll see a proposal once again that will take a California state budget that has some flexibility and room in it, at least not knowing about these federal changes, and will put those dollars aside as much as possible for use to deal with whatever's coming next and not knowing what that timeline looks like. So one of the things we haven't talked about here, recognizing that this is a pretty grim conversation on a lot of fronts, is about where there might be some opportunities. And I think about the earned income tax credit, where that was, at least in its early formations, was a conservative idea, has had some support in the Ryan budgets over the last few years. And we have our new California state earned income tax credit. And just wanting to sort of see what folks, if anything, are hearing about that. I know, Edwin, you're not necessarily an expert on that, but what the center is saying about it?
Sure. I mean, I think if you look at the Bush tax cuts that were enacted at the beginning of President Bush's administration, big tax cut, heavily weighted towards high income, but certainly there were a number of provisions that helped low and moderate income families in terms of taxes, child credit, things like that. So even though there will also likely be a very large tax cut package trying to move through Congress in 2017, trillions of dollars in tax cuts, that may be an opportunity for an expansion of the EITC. And as Chris mentioned, it's something that's been supported by Speaker Ryan, other congressional Republicans, as well as, of course, Democrats, that those kind of opportunities may be part of a package, especially if the package is moving through. There's no stopping that kind of package, but there still might be an opportunity as part of that to garner some bipartisan support to help low and moderate income families better able to, thrive and meet their needs.
Frank?
In addition to that, we had some hope that an infrastructure deal could create an opportunity for arguing for perhaps set-asides for people who are on TANF or for low-income folks. The proposal that the president-elect came out with wasn't much of an infrastructure deal, and it was heavily criticized. And perhaps it's his first shot across the bow, and in the course of negotiating, it can be sort of less just sort of blatant tax credits and more direct infrastructure investments. And if that's the case, there are perhaps opportunities to see if states could be incentivized to leverage some proportion of those jobs for very poor people or for people who are trying to work their way off TANF or SNAP.
And similarly, there's some conversation out there about something in the child care tax credit arena. The Trump administration has expressed some sort of interest in that. Both campaigns had proposals in that. Here again, probably focused around tax credit strategies, which have traditionally been more acceptable to conservative leaders. And early on, the proposal seems to have it going way up the income scale, which makes folks a little nervous about both the revenue loss and whether it's sort of designed effectively to help people. Have either of you heard anything? I'm surprising them with this question, which I didn't tell them was going to be on the list.
It's our sense that the tax package is, much further away from coming together. I mean, I think that the first thing is ACA repeal. There's no ideas on replacement, and there's no ideas on the tax package yet. So I think it is definitely further down the road. So we don't know yet what opportunities and sort of what are the priorities of the incoming Trump administration will be, outside of the big high-income tax cuts.
And as both Frank and Edwin have alluded to here, the real question is if there are opportunities and there are things we might like that we think would help low-income Californians in some fashion, what are they packaged with? What's the overall deal look like in that regard? And how hard is that to support, whatever the case may be, for those folks, for organizations who are advocating for those communities? So we're ready to start taking questions and answers. We can kind of keep talking here, but I'm already seeing some hands go up on this side of the room. And reminder to those of you online, we'll be watching for your questions as well. And if you could identify yourself, that would be great.
Okay,
and your
great.
organizational affiliation, if possible.
Okay, so I'm Janice Canallen. I'm with the Children's Defense Fund of California. Assuming that federal advocates can fight off the attack, what we see as an impending attack on EPSDT for children through a mom and apple pie, perhaps, advocacy, what do you think the impact of a repeal on ACA would be on benefits and services for children in the state who may technically still have an entitlement in place, but there's so much of a hole created in the healthcare budget that perhaps that wouldn't be able to be, it might be an unfunded mandate, essentially.
Yeah, I mean, certainly, the lost federal funding would cascade through the entire Medi-Cal budget. And then it's also, we've seen increases in enrollment among previously eligible kids as a result of the Medicaid expansion. Publicity, outreach, when you cover parents, you bring in kids. So I think, that certainly will have an adverse effect on low-income kids in the state. And then looking forward, as you point out, if there are efforts, as are likely, to pursue a block grant or per capita cap, that is likely tied with additional programmatic flexibility for states, including on benefits, and EPSDT would likely be a prime target for an elimination of benefit requirements that currently exist in Medicaid, so that you not only see certain populations no longer have to be covered, maybe there's no more individual entitlement, states can set waiting lists, cap enrollment, but also there wouldn't be mandatory benefits, including the comprehensive EPSDT benefit for kids.
I also think the destabilizing of the insurance market will increase access issues even if the entitlement isn't changed a bit. I mean, we know in the EPSDT program there are waits. There's difficulty accessing specialty providers under the existing program. So to the extent that the entitlement stays, but the insurance market's destabilized, that it's that much longer to find a physician, or that much more difficult to find a physician, that creates greater access barriers, I think.
Hello, my name is Ipiani Lockhart with California Partnership. I was wondering, with what's about to happen in the near future, do you guys see this as an opportunity to make the push for the argument for a single payer system again? Should we be making that push again?
Well, I think that if you look at states that have explored single payer, that requires obviously significant revenues, and states like Massachusetts that had done a health reform on its own prior to the Affordable Care Act relied heavily on federal funding. And if you're looking at both ACA repeal as well as all the other budget cuts that are potentially looming for states in 2017, I think it's hard to see how that's a realistic possibility, because such a big hit on the budget that the state has to increase revenues just to backfill some portion of those cuts. There's very little, I think, potential for expanded coverage to completely backfill and more the coverage that's going to be lost under a looming ACA repeal. So, I think there's a lot of questions about that. I've heard questions from others on this issue, but I think that's the important thing when you think about the totality of the state budget and what's at stake in terms of federal funding. We haven't even talked about what's called non-defense discretionary spending. This is funding that the federal government appropriates on an annual basis. About a third of that comes to states, including to California, and that non-defense discretionary funding is also going to be under assault. President-elect Trump wants to increase defense spending. There's automatic cuts that are looming that Congress has averted in the past, but it's less likely that those cuts will be put off again, or they may fall exclusively on the non-defense discretionary side.
I think a better sort of advocacy posture, rather than going back to single payer, notwithstanding the fact that I think it's a better system, is exploiting the parts of the Affordable Care Act that the public really likes. Because things like the prohibition on excluding people with pre-existing conditions, the limits on age-based rating, the coverage of kids up to 26, even premium assistance, those are very popular. And to the extent that there's political pressure against doing those, it's much harder to unwind other aspects of the Affordable Care Act. For example, and most people know this, the insurance companies, health insurance companies, really need the individual mandate. And their willingness to go along with the Affordable Care Act, the components that prohibited them from excluding you if you have a pre-existing condition, for example, were conditioned on the promise that they were going to get healthy bodies into the risk pool due to an individual mandate. And so I think the unwinding of the Affordable Care Act is not without political peril, and I'm not so sort of Pollyanna to think that this is going to stop all bad things. But if the politically popular aspects of the Affordable Care Act are difficult to unwind, some of the other aspects are become difficult to unwind as well. That assumes that anyone continues to care about health insurance companies and hospitals, who are now both saying, "Hey, wait a minute, this could be really bad." And Senator Susan Collins and Senator Orrin Hatch are saying, "Well, maybe we shouldn't do this repeal now, replace later. Maybe we should be more thoughtful." I think we should make it really hard by trumpeting the things that the aspects of the Affordable Care Act that the public really likes, rather than saying this isn't. Yeah, we should throw Obamacare out and let's go back to the drawing board and try for single payer.
So I just want to add something quickly to that, which is I think as the state figures out what the landscape looks like here, the question of what the state wants to do, as California leaders have signaled a willingness to go it alone in some respects, the question then becomes how to pay for it. And I think it'll be hard to sort of conceive of this in the next year or so, but there's some point in the future, if a lot of these changes happen, where the revenue question comes into play relative to what the state wants to do to provide and extend some of these services to those who would be losing them under some of these federal changes. So that's not something that I think is a 2017 question, but I think it's a 2018, 2019 question to watch for.
Can I ask a question of Edwin?
Sure.
Because this is my question. So you have some Republicans who are clearly nervous about bombing the Affordable Care Act. Health insurance industry that's very nervous. The hospital industry that's very nervous. Is there enough political pressure, and there are very popular aspects of the Affordable Care Act. Does that create an environment where we can expect maybe a mitigation of the worst, or is it such that the campaign promise to repeal was so powerful that those other forces aren't going to mitigate?
Well, as I mentioned, I think the goal of this national coalition, Protect Our Care Coalition, is to raise concerns about going ahead with repeal without replace, which is the repeal and delay is effectively repeal. And I think that congressional Republican leaders who are committed to repeal know that there's looming pressure, which is one reason why they're moving ahead on such an accelerated time frame. But the hope is that enough, particularly Senate Republicans, say, hey, we're still in favor of repeal, but we want it tied together with some other package to maintain coverage for some significant portion of those who are otherwise going to lose it. But I think that's, and the industry is starting to weigh in as well, hospitals, insurers, and others. But the opposite side of the coin is President-elect Trump, congressional Republicans ran on repeal, promising repeal on day one, and their base of support also supports repeal, even though obviously a fair share heavily rely on the coverage the Affordable Care Act provides.
We have another question.
Hi, Callie Freitag with the Legislative Analyst's Office, and actually soon to be with the County Welfare Directors Association. Frank didn't plant this question. I want to talk about the block grants. So, given the significant limitations and understanding that block grants have these limitations, are there any positive lessons that we can learn from existing block grant programs like TANF or the Children's Health Insurance Program that California could take with an impending like Medicaid or SNAP block grant?
Sure. I think if you look at sort of the universe of block grants, the Children's Health Insurance Program is the one sort of outlier. It's a successful program, supported healthy families, now Medi-Cal here in California. I think the difference with CHIP and all the other block grants is that it has been deliberately overfunded. That is, it acts like an open-ended financing system, like in Medicaid, when states have run out of funding since its inception in 1997. Congress has actually stepped in to provide additional funding, so no state has ever run out. If you look at all the other block grants, whether it's TANF, Social Services Block Grant, many others, we've looked at it, and it's pretty clear. They were block granted. They don't rise with need, particularly during recessions. They don't have a countercyclical function anymore. The real value of the block grants declines over time. If you look at the Social Services Block Grant, in real terms, it's down 3/4. TANF is down about 1/3, and as I mentioned, because block grants are usually tied to flexibility, states aren't using it for core function. Only about half of the funding nationwide is actually going to core assistance that was previously funded by AFDC. So I think, if you look at block grants, the lessons are they're about reducing federal responsibility, shifting costs to states. The magnitude of the cuts are significant. As I mentioned, the $1 trillion in Medicaid block grant in the House Republican budget, that's a cut of about 1/4 on top of repeal of the Medicaid expansion over 10 years. And by the 10th year, it's 1/3 in terms of the cut, and the cuts get larger and larger because the block grants and or the per capita caps are explicitly designed to not keep pace with rising healthcare costs. Usually they're trended up by general inflation. We know healthcare costs, even in Medicaid, rise faster than inflation. So I think the lessons are, it's a shift in responsibility, a shift in costs, a shift in risk to states, and it's also a shift in responsibility to states where the federal government comes up with a complicated formula and then gives states, leaves states holding the bag in terms of how you're actually going to compensate for those funding cuts using that new flexibility. So the flexibility that some states may be attracted to is really the flexibility to cut, not the flexibility to innovate or do positive things, make improvements to the program that federal rules right now may be getting in the way of.
Hi, my name is Angel Garcia, and I'm from the California Workforce Development Board. My question's also in regards to block grants, in particular the SNAP ENT program, and the federal efforts to scale up the program by FNS. We're working on a variety of efforts here in California to upscale that program, but how would a block grant affect the currently uncapped federal match dollars for programs and services for individuals participating in that program? That's a real big worry if we're trying to scale up the program in California.
Yeah, I can't speak to the specifics of SNAP. That's outside of my area of expertise. But in general, you're in a block grant, you're putting a state in a fiscal straitjacket, and so it's unable to meet its current demands, maintain current enrollment, let alone enrollment that may rise, for example, due to a recession. So the ability to do, expansions, improvements, they're all drastically curtailed because there's such a restriction of federal resources, with those restrictions getting larger and larger each year, that the state is really just trying to salvage what it can of its program as those cuts get deeper and deeper each year.
Let me just say, if I could, before you follow up, I think what's going to happen to SNAP is much less certain. And I think if there is a block grant, we wouldn't know what the base year is. And so arguably, the more we gear up SNAP ENT, we could drive up our spending such that a block grant, we're better off than if we don't, because we'd have a bigger base. I'd also, if you look at what I discussed earlier, the incoming CMS director and this interest in work, no public assistance entitlements without work. I think SNAP ENT could be among the more popular aspects of the program. So I would say, like, step on the gas now on SNAP ENT, rather than let the fear of the unknown cause us to voluntarily retrench. I think we're probably shooting ourselves in the foot if we do that.
The SNAP ENT program really requires, especially engaging them to be a part of the broader workforce development system, really depends on partnerships and leveraging funding. So I agree with you, because if we're looking at now and who's participating now, it's not a mandatory program. Only certain counties are participating now, but we have a lot of interested folks, counties, and partners who really want to build up that program. So thank you.
And just real quick, for anybody who doesn't know, could somebody please decipher the acronym involved?
Employment and training.
Thanks.
Hi, Nicole Boucher from Color Democracy Fund. Just want to pivot a little bit to state governance, because in 2 years we're going to have a new governor. We're going to have a lot of seats that are open for the first time, and just looking at the issues we'll be dealing with, we'll be halfway through a new administration. And, love Jerry or not, he's an expert at governance, and he's an expert. He could probably write the state budget in his head or on a cocktail napkin at this point. So my question is, and this is also maybe a question for the researcher that was on earlier that didn't want to answer questions, but, what should voters be thinking about as we get into a pretty heated gubernatorial race? Like, what are the qualifications, and what should we be thinking about of how we want our state to really take leadership with a whole new cadre of leaders in 2018?
So I'll start on that one. I think that's why I just want to confirm, I think that's why the governor's race is going to matter even more now. I think what's going to happen is we're going to learn a lot about what the new landscape looks like. Some of that's going to be bad for the communities that a lot of the organizations in this room are trying to help and represent in some fashion. And California's leaders, at least at current, have...
Hi, Jordan Lindsay with the Senior Services Coalition. I'm going to pivot back to block grants, and let's just assume Medicaid block grants do come down our way.
No.
Okay. We're not going to assume that it happens. I much prefer that. Worst case scenario, it does. And comparing other block grants as well as other states and what has happened in other parts of the country, there are so many competing interests within Medi-Cal. Can you paint for me that rosy picture of what the competing groups now, what is their new reality under a block grant? Well, and obviously the new reality is limited funds, but in other states and other programs, is it all of a sudden just a blood sport, or is it not?
In California, I mean, if you look at our program, we definitely err on the side of expansive eligibility, and to some degree, you could argue that we sort of partially pay for that by paying really bad rates. And that's why the capitation proposal is so dangerous. And so I suspect that should really bad things happen, and I hope they don't, but should they, I think that this most significant pressure for the legislature and the governor is going to be minimizing the extent to which people go back to being uninsured. So I think maintaining as broad an eligibility as possible will probably be the most significant driving pressure, and I think that puts pressure on other needed aspects of the program, like adequate rates, so that people who are eligible can actually find a doctor.
And I think it's a zero-sum game, and I think that it's also important to remember that seniors and people with disabilities on the Medi-Cal program and the Medicaid program nationwide, relatively small share of total enrollment, but obviously have much higher costs, acute care, long-term services and support needs, and so there's sort of this pressure where if you try to protect those two groups, then kids, non-elderly adult parent population would face even deeper cuts. And conversely, because the cuts are so large, going after benefits eligibility for seniors and people with disabilities means seniors not getting their homing-based services that they need, people with disabilities not getting the supports they need. And when we looked at the House Republican budget plan, they actually gave states a choice. You can either take a block grant or a per capita cap as long as that $1 trillion cut is still met. If you did just a per capita cap, we were showing how large the cuts are, because you're really cutting only on the benefit side rather than the eligibility side under per beneficiary cap. So if you try to maintain enrollment, which it seems very hard to do, then you're talking about 50% cuts in spending per beneficiary. And if you try to protect seniors and people with disabilities, federal funding for kids and parents would largely disappear. So it gives you a sense of just, how tough it is. And in general, you'll see cuts across the board, across all populations, across all services.
Great.
I'm Lisa Coleman with CALCOA, the California Long-Term Care Ombudsman Association. So kind of following up on a senior services question, we know that Medi-Cal is the primary last resort for long-term care providing in the state. We have about 1,200 skilled nursing facilities in the state with about 100,000 beds. And we know statistically 65% of those beds are Medi-Cal. How do you cut a benefact when it means the person's in the bed?
Well, I think that's obviously a huge concern. And is it going to be, is it going to be some sort of caps on the number? Right now, nursing home care is a mandatory benefit. And as you said, Medicaid's the primary funder of long-term care in this country. So I think, that obviously raises huge concerns about what that means for both existing nursing home residents, but also future nursing home residents, those who would otherwise qualify for Medicaid in the future, who may not be able to get it now, let alone those who have long-term service needs but aren't able to get on the Medicaid program today. And that's not even counting the other assistance that Medicaid provides seniors, including help with Medicare premiums, Medicare deductibles, and cost-sharing charges. And we haven't even talked about potential looming changes to Medicare that may shift costs onto Medicare beneficiaries, like Medicare privatization or premium support, changes to cost sharing, raising the eligibility age, all of which would shift cost onto seniors. And if you're also restricting the ability to access Medicaid at the same time, that's a double hit on seniors' ability to afford the services they need.
We've got one.
Yell it out.
Jerry Chaffee, California Chronic Care Coalition. I just want to mention a couple other pressures on Medicaid, or Medi-Cal. Number one, I don't know the number in California, but nationwide, 40% of the Medicaid budget goes to the people who are physically handicapped. That right off the top. So that leaves 60% left for everything else. So that's even more pressure. And if you don't change the eligibility, there is no way that you're going to be able to pay for all the programs. It's impossible. Number two, what has not come up once this morning, but should be brought up, are the high cost of specialty drugs. For example, the Hep C drugs, and the blockbuster drugs that are coming out every year. Those go out of the Medi-Cal budget. So, that's another. Those are other big hits that have to be paid for. And by law, if a drug's been approved by the FDA, Medi-Cal has to pay for it. And so if you don't get you'll get discounts. That's automatic. But if you don't get all the big discounts, that's another huge hit on the budgets. So just
and I think it's that's raises a good point, because under a block grant or a per capita cap, federal government shares in higher unanticipated costs, so like when a blockbuster drug comes to market. But under those kind of capped approaches, the state will get no additional federal funding. The state's responsible for 100% of those additional costs. So either the state has to absorb all those costs, or because of the additional flexibility a state would receive under a block grant or per capita cap, maybe the state would no longer have to cover some of these drugs, even if they are life-saving and huge, breakthrough treatments like the hepatitis C drugs. Very costly, but obviously they cure hepatitis C.
So these last couple of questions remind me just that every time we talk about healthcare reform, no matter who's proposed it in this country, just how complex it is. And some of what needs to happen is that people need to sort of blast out about some of these issues, right? Sort of, somebody's going to lose a bed, somebody's life's going to be endangered, somebody's costs, prescriptions of some kind are going to go up dramatically. The more that kind of information gets out, the harder it is to make a really rapid vote to just repeal something wholesale, and it gives advocates more time as the process slows down to put more pressure on as the months go on. So, those stories need to be heard more and more from the advocacy community about what actual Medi-Cal changes might mean.
Martha Zaragoza Diaz with the California Association for Bilingual Education. And this coming year, the next 2 years, will be very important in terms of following the federal budget. Does the Budget Center have any idea in terms of whether you're going to be providing information to the public with specific significant federal budget projections or proposals?
So, I think it's safe to say that you could add the word federal into our name somewhere over the next several years. We already have mapped out a work plan that will be doing a lot in terms of tracking. We're inventorying federal programs right now, who's affected, how much is spent, how many dollars come into the communities. You've seen us put out some information already, county by county, Medi-Cal eligibility numbers, total number of uninsured, the drop in the number of uninsured. You will see that kind of work coming out from us on CalFresh, on proposals that have anything to do with other human service programs. We're watching the education arena as well to see what happens, the criminal justice reform arena. Maybe the blessing of a not very interesting wait-and-see budget year is that we'll be able to have the time and the space to do a lot of that federal budget work. But it could also be chaos here in California, and we'll be doing just as much on both fronts. But I can commit to you we'll be available and a resource as much as possible. Other questions? We haven't covered a number of other issues here today. We're happy to keep doing Affordable Care Act, human services, but there's some other issues out there. If anybody has questions, I see a couple.
Sorry, I have an ACA question.
No problem.
Earlier, I think, Edwin, you mentioned, and even Frank, that another scenario might be no repeal, but other changes to the Medicaid program, for example. And I'm curious, what does that look like when you maintain a mandate with tax penalties associated with it, et cetera, et cetera? You may or may not have a marketplace because insurers are not going to want to participate in that kind of a chaotic situation, yet ACA is still the law of the land. Meanwhile, states are looking at how they adapt to a block grant scenario. I'm just curious, what does that world even look like from the perspective of the state and also from the perspective of the consumer?
Well, I think if ACA repeal is slowed down, I think that would also slow the momentum for block grants and per capita caps. So, I think probably you could see a more likely scenario if ACA repeal is slowed down. In the interim, the new HHS secretary, presuming the nominee Tom Price takes office, the new CMS administrator, they push proposals related to existing waivers, wanting states to change course, giving states additional flexibility through these waivers, taking steps to potentially restrict how some states finance their Medicaid programs. Those kind of things that are could be harmful, particularly for states that want to maintain their programs as they are and continue to move forward, because that may not be consistent with the policy direction of the new administration, they may say, no, even though that waiver's already in place, we want changes in exchange for X, Y, and Z. So that's would likely happen irrespective of what happens on ACA and Medicaid, though I think that the big threats to Medicaid I think would likely be slowed down if ACA repeal is slowed down. But if ACA repeal is quick, then that accelerates a push for replacement, which in turn, I believe brings Medicaid and Medicare more on the table as a way in part to offset the costs of any replacement.
I know we have another question, but I want to bring something in from the first part of the session today where we had someone who asked the question of, can California actually sort of backfill, right? Or is there some reason why the federal government could stop California from actually deciding to maintain or extend eligibility in some fashion? And Frank, you and I were in the back of the room. You commented initially. Edwin, I don't know if you have thoughts, but what your response to that? Because we didn't answer it earlier.
No, there's not. I mean, we've got state-only Medi-Cal programs now. It would just be a matter of political will and money.
Hi, Chauncey Smith with UDW, AFSCME Local 3930. You raised a question in regards to seeking questions on other subjects, so I have one. There was a lot of statements recently made by the leaders of our legislature, De Leon and the Speaker, in regards to not doing what Trump says that he wants to do, and trying to fight back and protect the diversity of our state in a wide variety of ways. Say Jerry agrees with them and tries to take some actions to do that. What do you think about the likelihood of some pushback from the federal level in terms of spending for all of the different types of programs that our state relies on, and then the whole idea of Cal exit and being independent and stuff like that?
So, this is probably the question we've received at the Budget Center the most since the election, was sort of what leverage does the federal government have, whether it's on cities through the sanctuary city concern that's been raised, or on the state overall. At the state level, there's certainly leverage, right? There are dollars that flow in a variety of ways, as you saw in Scott's presentation earlier. You've heard about some of the leverage earlier, the waivers that might be more easily taken away politically. But that said, the state has recourse, right? I mean, some of these are programs that have been put in place with intent. There's both legal recourse the state could take to halt some of those federal actions that could delay those actions because they'd be tied up in courts in some regard. There's also legal precedents that sort of say, hey, that limit the ability of the federal government to be coercive through programs. I'm not a legal expert on this, but I've done a little bit of reading on it. And if programs are sort of existing in place, it's harder for them to come and be coercive about it later. If they're creating new programs, it's a little bit easier for them to put stipulations in place about the behavior they expect in states. But there's a lot of gray area there, and my sense of it is one of the most important policy environments we're going to need to watch over the next 4 years is the legal advocacy world, where I think a lot of things are going to get challenged at the state level. If you think about both the George W. Bush administrations and the Obama administrations, it was states, governors, and attorney generals who actually challenged those administrations' policy proposals in some fashion, including Obamacare. And I think you'll see something similar this time around. I don't know if my colleagues have thoughts.
Before and immediately after the election, our members, the people that I represent, administer Medi-Cal, CalFresh, CalWorks, and a variety of other programs. We're getting questions from applicants and clients about the privacy and security of the information that they're providing us, because of the fear of information being shared that would help or that would aid in, mass deportations or other unfair targeting. And we're sort of reinforcing our sort of legal status with our state partners to ensure that information, which is, I don't know, Kathy, 15 million people probably that we've got across all the programs, 15 million people in our state, we've got some information in a database that we use to determine their eligibility for programs is not information that can allow them to be individually identified. for any purposes related to immigration, and for any purpose other than the delivery of the benefits to which they're entitled.
One of the things I would add here, I used to work for association that worked with city governments nationally, and in one of the more heated moments of the national immigration policy debate. And one of the things I think you will see happen is I think you can have California state leaders and California local leaders who will say that they are going to fight whatever the sorts of policies around immigration that might come down from the federal government. And they will, and they can do that effectively in their own practices and procedures. There's still the problem of the confusion that gets created by different agencies of government implementing different policies and practices. And so it's it can depress, not sort of emotionally I'm sure too, but sort of the activity that immigrants are engaged in when their local police department is acting a certain way, in a sort of community interest sort of a way, and the next day there's an ICE raid. And so the disconnect that can happen between what federal officials are doing and what state and local officials are doing is still something we're going to have to be very attentive to in terms of trying to educate, provide information, and make those communities feel more safe in our state.
Hi, Judy Darnell with the United Ways of California. I love Frank's idea about stepping on the gas, and whether it's in relation to SNAP and CalFresh or Medi-Cal. My question is, couldn't the federal government, when they're doing the formulas, like say, as of the end of whatever it was at 2016?
Yeah, so if you look at Speaker Ryan's prior block grant proposals when he was chair of the House Budget Committee, the base year was 2 or 3 years prior to the start date of the block grant, and then trended forward by inflation, whatever the inflation factor is. So there is no block grant proposal for 2017 yet, in part because they don't want anyone to model it until the last second, which we would plan to do at least nationally, if not state by state. But a state may or may not be able to build in some more recent spending. It all depends on the formula, how it's actually put together.
And I'd like to say that I think it's important to look at prior proposals to get an idea of what we might be after, but I don't think we should look at it as a blueprint for what is going to happen. It's one thing to put a block grant proposal forward when you know it has no chance, and therefore no Republican opposition needs to sort of weigh in. I think what Mr. Ryan put on the table may be very different than what's put on the table a year from now, because of the possibility that it might actually happen. And I don't think he had any illusion that what went on the table in the past would.
Yes, ma'am.
Hi there, Shahara Hyatt with the California Homeless Youth Project. We know that the state of California has a housing affordability crisis. We have the largest share of people experiencing homelessness in the country. We've seen some traction on this recently in our legislature, but historically not nearly enough to meet the need, and that's still true. I think I, like many other people, have been horrified by so many of the appointments that Trump's been making to these federal cabinet positions, including Department of Housing and Urban Development, Dr. Ben Carson. And I'm just so curious if any of you could speak a little bit to any of the conversations happening at the state or federal level around housing and homelessness.
My guess, Shahira, is that the homelessness issue is not going to go away, and it will be one of those things. I mean, as the conversation in Sacramento, I think it'll be one of the few issues that gets discussed for new investments. Because of the magnitude of the crisis, and frankly because of the politics around it. I mean, when homeless people were only in ghettos or Democratic districts, there wasn't nearly as much interest in Sacramento as now, where it's hard to find a community where we don't find people experiencing homelessness. And so I think between housing and homelessness and immigration and deportation defense, I think there'll be the two areas, at least two areas, that get some discussion about what the state can do to move the needle forward, even in light of the threats, immediate or future.
I would just add that states on a bipartisan basis have been doing a lot to integrate health and housing. National Governors Association and others have been promoting that. There's been a lot of progress in that area to integrate services. I think it's important to point out, particularly as we're talking about repeal of the Medicaid expansion, that by taking away the expansion, many of the people who are homeless now who are getting those integrated services, they're newly eligible because of the expansion. They're single adult. They weren't eligible prior to that. And without that expansion, that kind of progress gets halted, if not reversed. And it's another key feature of the benefits of the expansion. And we've seen that too in a number of states struggling with the opioid crisis, that Medicaid coverage to deal with that problem was coming along with the expansion, for example, in Ohio. And without the expansion, or the funding for the expansion, those efforts also would be curtailed.
Yes, Nancy.
Hi, I'm Nancy Stroll, and I have no current affiliation. I would like you to talk a little bit about TANF and childcare, and I think certainly the childcare is in two parts. There's Ivanka's gold-plated tax policies, as well as the effect on, the TANF and CCDBG block grant. So that's my first question, are those two. And then my second question, so it'd be really good to hear a little bit about kind of the national advocacy strategies and the California relationship to those. And I'm old enough to remember when Reagan was elected, and one of the things that was really important was to link the state, national, and local advocacy strategies.
Frank, do you want to?
So I guess this is what we're hearing. Evan, I don't know if you're hearing the same, but it seems like TANF is the lowest priority among all the programs that you've heard in terms of likely federal action. It's in so many states, it's withered to virtually nothing. California is an exception. I think we've got a better program. So I don't think there is much of a national dialogue, at least one that we've heard about or been part of, with respect to sort of immediate thinking about advocacy to position for TANF reauthorization. And I'm not as familiar on the CCDBG side, so I thought I'm going to defer to Edwin, see if he has a sense.
Yeah, I'm not sure about TANF. There has been efforts by Speaker Ryan to merge a bunch of smaller funding streams into what he calls like a poverty opportunity grant, as a way to both cut funding, but also just, those funds would no longer be dedicated to certain purposes. So that's what I'm most familiar with, but I think that's right that, TANF isn't getting as much attention just because the focus is on SNAP and Medicaid in terms of low-income changes.
And partly because the national entitlement was already eliminated.
Yes.
And the promise of the block grant never materialized. And I think what's been done to TANF is what we need to be thinking about as we think about what could be done to other programs.
Just a real quick plug there. We actually have a piece coming out in the next few days, actually looking at the unmet need in California around subsidized child care. So watch for that. And who knows what's possible in that regard, given what we've just described as the landscape for the 17-18 budget. But let's just say it's a big number.
Hi, my name is Sonia Ed Bennett, and I'm with the Salvation Army California. And so that there's a couple questions that have led really well into my thinking. Rather than panicking about the individuals that are going to be impacted by the cascade and the ripple effect that will take place with all of these potential cuts. I'm thinking about the nonprofits and the community-based organizations that are already fairly tapped. But how might we really strategize and be proactive, working with the government, realizing that the funding is going away, potentially, right? I mean, this is, that funding is going to get less and such. How might we work with departments such as yours to prepare and anticipate those individuals that are going to be knocking on our door for housing, for food, for even child care, for, you know, we, for example, have early care and education programs throughout the state funded through Title V. So, you know, these are families that are going to be impacted. How could we best work and prepare?
I think it's a great question, and I think, you know, our members work with community-based agencies throughout the state, and those partnerships are important. There's a tricky political angle to this, I think, and that we often see associated with monstrous cuts the argument that the nonprofit sector or the faith-based sector will fill in. And so I think we have to try to enhance our partnerships with those sectors without contributing to the narrative that you can take 20 million people off health care and expect churches and CBOs to pick up the slack. And that narrative is strong. And so it's sort of not a direct answer to your question, but it's something I've been thinking about. I think we need to resist the narrative and defend publicly funded entitlement programs, and at the same time argue for and work with faith-based and community-based agency partners to help. And we're in waters where that's a sensitive balance. It's one that can be achieved, but I just think it's something we have to be aware of.
I couldn't agree with Frank more on that one. One of my great fears going into the next couple of years is that we, the nonprofit sector, of which my organization is a part, doesn't realize the need to emphasize the public policy part of this in an effort to backfill a scale which it can't backfill. And so all of us need to be even more active on the public policy front than we were before to make the case that there's a government role that is significant and is needed here. I think that's our last question. Let me do a couple of real quick thanks. Thanks once again to the California Endowment for hosting us here. I want to thank my staff who did a lot of work to put together all the logistics and make this go smoothly. You see them around the room here. They've done a wonderful job. And thank you to our speakers, Edwin and Frank, for joining us here, and to you all for your questions. Thank you.